Welcome back. I'm very much looking forward to this panel because if there's any issue facing countries all around the world where information technology can have a profound and far-reaching impact on our societies, it's healthcare. And one of the themes of this entire event has been that we have these old industrial age models of everything, where something in the center pushes out something to passive recipients. And it's certainly been that way with healthcare. And rather than, I'm a teacher, I have knowledge, you're a student, you don't, get ready, here it comes. It's, I'm a clinician and I have knowledge. You're a patient, you don't. I deliver healthcare to you. You're a passive recipient. Oh yeah, and you only get it when you come into the system, which is why it costs so much. And please don't collaborate with anyone else because I'm the source of knowledge, and don't go on the internet. That's the worst thing you could do because you'll find incorrect information. Well, we can now move towards a radically new model of healthcare. And to lead us through this discussion is Bill Pascal, Chief Technology Officer for the Canadian Medical Association, where he's responsibility for shaping the strategic direction and policy of the e-health agenda for the Canadian Medical Association. And he's worked with economic policy, social policy sectors, the federal government level. It's also a very interesting background. He's an electrical engineer, a certified accountant, and an urban planner by academic training. So please welcome Bill Pascal.
Well, welcome. The discussion this afternoon is now we're going to change the lens up from some of the other areas we talked about. We are going to focus on the healthcare sector. One of the interesting things about this sector, this is one of those public policy areas where everybody agrees on what the issues are. Everybody agrees on the vectors that we need to take to resolve the issues. So one would say, why haven't we made a whole lot of progress in this area? So what are those pressures that's confronting us and also confronting all developed countries and to some extent some of the developing countries? First of all, it's the demographics. We're all aging. In Canada, the estimates are we're going to add 1 to 1.5% to our GDP because of the added cost for the elderly demographics we have. But what that doesn't pick up is the indirect cost, which is the caregiver costs that go with trying to deal with an older demographic group and the pressures it starts to put on family, the voluntary structures in the country, which I haven't seen anybody put some dollars around to. The other thing is that all of the democratic countries are developed countries are also noticing healthcare is actually eating up a larger percentage of the budgets of the governments. And in fact, in Canada, we've gone from about 8%, we're up to 11.6%. The U.S., I think, is close to 17%. And all our forecasts will suggest that our percentage of our budgets are going to increase over that period of time. We have a delivery system that's fundamentally been built for the 1960s. It's a model that's built around hospitals. It's a model that's built around very well-defined rules of providers that has not fundamentally changed since the turn of the century. We've also got a delivery system that's very, very inefficient. Don Drummond, who was the former chief economist for the Toronto-Dominion Bank, did a study in Ontario and he estimated that approximately 30% of the healthcare delivery is inefficient. I have some colleagues of mine in the research world that even estimate that goes up as high as 50%. The question is, how do you actually start to get your hands around driving out some of that efficiency? So what are the vectors going forward that everybody is saying we got to focus on? The first thing they say is we got to get off this focus on health, and we got to put the focus on health and well-being. Only 20% of your health and well-being is attributable to the care system. It's the other 80% that deals with where you live, your social background, your social networks, etc. Those are things that we got to start spending more time and energy on and figuring out how we actually bring that together. The other thing we have to start to do is we got to move where the care delivery is best delivered. And that means moving it out into the community, closer to where people live, and actually start ensuring that the types of interventions that take place at those levels are the most appropriate ones. The other thing, as part of that, we got to start building the care system around the patient. Right now, the care system is built around the physician or is built around hospitals. That whole thing has to be turned on its head. The other thing is we got to start having a system that's far more accountable, which means you need metrics to know, are you going up, down, or sideways? And that means we're measuring the type of care provided, how providers are providing it, the roles in there. And it's one of those unfortunate things that we have tons of information in the care sector, but we don't analyze it, or it's not the right type of information to actually do the analytics and feed that back to the care providers so they know where they need to start putting time and attention to improve. The other thing we have to do is we got to adapt to the new consumer. We have a consumer now that wants to have a more activist role. And we got to start taking a look at the personalization of care from where we are now, which is really, we look at care from a population health. All the research we do on new drug therapies, et cetera, we do it in cohorts, but we never drill it down to the individual. And we are now entering a different phase in care because of some of the technologies and genome sequencing. We now have capabilities that we couldn't have thought about 10 years ago. So all countries, especially all the provinces in Canada, are pursuing these. Some are a little more successful, but you're not seeing anybody do what I call a large-scale transformation. Healthcare, in my estimation, is one of the last sectors that actually has gone through what I call a business reengineering. All other sectors have gone through to figure out what are they trying to get out the door, how do they best organize themselves to get it, then they bring and digitize those processes to maximize the returns on it. We have not done it, and there's some questions of why haven't we done it? Why is it that the care sector seems to be held immune from these types of changes? They almost get compartmentalized, and we really don't see these major moves going forward. In part, it's the nature of care. We're a very conservative sector. Our job is to keep people alive and keep them healthy. A physician is not going to go venture out with some innovative process if he or she does not understand what the potential implication may be for the patient. So there's a tendency not to get too innovative, and I'm putting some walls around that because there is a lot of innovation going on a very granular level, but not in a major way. There's a lot of resistance out there, and it's not orchestrated. It's just that people don't want to move too fast. Politically, in Canada, healthcare is called the third rail, and if you understand how subways run, there's that middle rail, and it's got 400 volts going through it. You do not want to touch that. And in the Canadian context, we have ministers talk about change, but no one really wants to do it because they're afraid of the reaction they're going to get back from the population. From the managers in the system, change is hard. And you've got a culture in the care system that's been fairly ossified. We're starting to see some changes in the different roles, but to a certain extent, the roles have not changed out there. And so what happens, you've got a culture. And as the old dictum says, culture eats strategy for dinner. And it's hard to make those changes. So this is not an area for the faint of heart to try to make changes. So is there an upside? My sense of it, yes, there is. And why is it there's an upside? Because we've got digitization of the care system coming in. There was a comment by a panelist early on where he says, the digitization is making the impossible possible. And when I heard that, I was thinking about the care sector, because I think we really are starting to get to a point where we're going to make what we thought was impossible, possible. And that's what we've got the panel here. And the panel is going to actually explore the digitization of the care sector in a number of different areas. And we've brought together an experienced, thoughtful group of people with varied backgrounds. And I think it's interesting, with the varied backgrounds, and my other observation would be we need to ensure we have people with varied backgrounds coming into the care sector to help us figure out how do we actually pursue those vectors that we know we have to change. We have, the first person on my right is Dick Alvarez. Dick is the president and CEO of the Canada Health Infoway, which is an organization in Canada that has been given a mandate to push out and ensure that the digitization of the healthcare agenda in Canada moves forward. Another interesting little part of Dick's background, Dick was formerly the CEO of the Canadian Institute for Health Information, which had responsibility and still does for doing the analytics in Canada with the information they collect from the care system. So he has another interesting perspective on what I call doability on the analytics, and he may want to comment on that, on some of the challenges that he faced that time. Next to Dick is Dr. Mark Blatt. Mark is a physician. He's the worldwide medical director for Intel in their Innovation Solutions Group. Mark's got a long history in trying to figure out how do you create the marriage between the care processes and how we deliver it and the integration of IT into the processes of care. And our last panelist is Ken Buetow. Ken heads up the computational science and informatics program at Arizona University. What I found interesting about Ken's background, if you look at it, he's put a focus on complex adaptive systems. And so certainly we know that healthcare is complex. Not quite sure how adaptive it is. So I'll be interested, maybe Ken would want to share with us a little bit on that. So let me take my seat and we'll start the process. Okay, we've got a number of questions that we've put together here, and I'm going to be rotating through the panelists to start the discussion, and I've asked the other panelists if there are points that have been raised. If they want to comment, by all means, please respond. So the first question that we wanted to have our three panelists talk about is, so if we look out to 2025, what's the healthcare system going to look like? And in that, what role will the digitization of that system help in those transitions? So Dick, can I ask you to take that on?
Sure. Thank you, Bill. Let's just go with a comment that you made a little earlier, and actually Don made in his opening comments, that it's a very paternalistic system, in many cases controlled by the physician, and Bill Jen said. But you know what? Physicians are very cautious. They don't actually venture out with some of this innovation. And that's absolutely true. I have no doubt your opinion is formed by the fact that typically it takes 20 years for a new clinical guideline or a new innovation, by the way, to go mainstream. So you're asking us where it's going to be 13 years from now as a vision. So this is more of a hope and a prayer that this is the way it's going to be. Hopefully, number one, we can start to move away from a system of illness to a system on wellness. That all those tons and tons of drawers and paper that you see will have actually disappeared. That they will be replaced by devices that are networked, connected, and where appropriate, are interoperable. That the data starts to move seamlessly together with the pictures and the images among all clinicians in a collaborative way and the organizations that are delivering care. Today, I think you heard from the IBM Watson, and so it gives us a lot of hope for improved real-time diagnostics, and I hope to see a lot of that in 2015. Consumerism is going to take over, I believe, and I hope, and we're going to see better access to care, again, because aspects in digitization. Bill mentioned the fact of the genome, and so we might start to move away from population-based medicine to more individual and personal medicine. And we're going to be absolutely awash with a variety of apps, from wellness apps to chronic disease apps to monitoring apps, etc. And so that is probably the vision that I see in 2025.
Mark?
I think you're absolutely right about the personalized trend and the movement of data and the increasing proliferation of digitized data being shared. But there's a consequence, I think, to how care actually gets delivered at an individual level going forward in 2025. First off, if most of you have ever touched the healthcare system, the major activity you do currently is wait. I don't care if you're waiting for an appointment, waiting in the doctor's office, waiting in the emergency room, you wait. You wouldn't really tolerate that in most other parts of your life. I think healthcare becomes more immediate. Healthcare becomes more available because it's delivered digitally. It's not necessarily delivered face-to-face. So I think that's the second major trend. Most other things that you do in the world, you're increasingly doing in a non-face-to-face manner. Banking, transportation, watching a movie, a TV show. I think you're going to start to get healthcare in a non-face-to-face manner. How many times when you actually go visit a clinician do you actually experience the fact, you know, they didn't even touch me. Why don't I spend all this time coming here and sitting here and waiting? So I think as video conferencing proliferates, as it becomes more available, as you can do it from your phone, your tablet, from a kiosk, from wherever, visits become more non-face-to-face. As a consequence of the visits being more non-face-to-face, they're more immediate. You can get health care at 2 a.m. without having to go to the emergency room because it's not 2 a.m. in Australia. The doctor is available. So there's the next trend. Healthcare is a local phenomena right now. I think increasingly healthcare becomes less local. I'm not suggesting that we're going to have the Da Vinci robot pull up to your front door and operate on you, but what I am suggesting is a lot of things that are already done will be done better with sensors, body sensors, haptic gloves, sensors that automatically upload data and are available for the analysis, feedback, and as a consequence, non-local, non-face-to-face, real-time healthcare becomes a reality. And that leads to the final trend. I think the cost diminishes. Wow. I think that's actually the driving force. Healthcare has become unaffordable. Governments can't. In Canada, the government helps pay for it, but the government can't afford it. In the U.S., citizens can't afford it. So I think to devolve the cost of care, you have to change the care delivery model. Non-face-to-face, real-time care supported by back-end intelligence that the citizen elects at the moment they actually desire and need it. I think that becomes increasingly the future. Not for everything, but maybe for more than half the care.
Well, I guess I'd leverage one of your opening comments, and we have to transform biomedicine and healthcare from a sector to a system. And I think we have to have a way by which all of the invaluable observations that happen in every clinic every day feed back in a learning, rapid learning health system where we liberate all of the information that's part of this system, and technology is critical to that activity. That information then permits us to actually move from this, at times, anecdotally based. I don't want to, obviously I come from the research sector and recognize the importance of guidelines, but on a day-to-day basis, we have almost no way to leverage the unique insights that each physician brings, so we actually liberate that information. We create a multidimensional space where all of the types of information that are critical to healthcare are leveraged. Clearly, one of the new dimensions that's going to emerge in this is going to be the capacity to have molecular and mechanistically based disease and treatment and health maintenance. But the second piece is much renaissance as revolution. We long for the day where the family physician actually knew all of the details of the person and the people of the care that was being delivered. In today's modern system, at least in the US, when a doctor has 12 minutes to spend with patient, they barely can come up to speed with respect to what's in the immediate piece of the chart, let alone have any deep context. And I think, leveraging what was said in other sessions, even at the lunch session, context is going to be king. And the ability to be able to deliver care in deep context. And to be honest, that you can't do that in today's universe without the digital revolution. It is the digital revolution that will allow you to step up and be able to see that context.
Yeah, just to go back to some of Mark's comments about moving more to virtual visits, we just completed a study that was published by the Conference Board here in Canada. And what we found, based on a survey, that on average, a Canadian takes 3 hours of work or of school for a 10 to 15-minute visit. When you start to aggregate that, the study basically says that if we move to aspects of virtual visits, Canadians could have, in the last year, saved something like 70 million visits, which would have meant almost the equivalent or more in terms of hours saved. So when for a country that's looking for productivity improvements in their workforce, etc., this is clearly one of the ways to go.
You know, from a capacity development point of view, as you move to the virtual care, heard an interesting statistic from Stuart Ferguson, running the Alaska Telemedicine Network. He said that the average wait time to see a specialist in Manhattan is about 6 weeks. The average wait time on the Alaska Telemedicine Network to see a specialist, 60% of the time, is about 1 hour. Wow. Same concept. Immediate, real-time care, because we're changing the way you access the system.
Well, and to be further heretical, then this will be heretical to this audience, is that virtualization may not have to involve a doctor. So if we actually liberate this information, there's, you know, with almost every other sector of the economy, we actually empower consumers to make tremendous decisions by themselves. Now, I recognize there's clearly the importance of gatekeeping for all sorts of things, but especially as we transform the system from a disease treatment system to a health maintenance system, empowering the consumer with tons of information actually makes it so that when you actually need to consume this precious resource of the nurse practitioner or the physician or whatever, you actually really need to consume that resource.
Well, the next question you had was about consumerism, so it feeds right into it.
Actually, I was going to build off your comment, because what was very clear in some of the other discussions that we had before this panel, talking about how digitization is actually giving more power to the consumer and allowing the consumer to get much more actively involved, or the individual actively involved in many parts of their life that 5 years ago we would have thought was not possible. So I'd like to, and Mark, I'll start with you on this, but I'd be really interested in your views on, given the type of consumer that we see now evolving in the other sectors, the consumerization that we're seeing that is moving into the care sector now, the very fact that we all have smartphones or iPads, and certainly in my community has the highest penetration by any professional group of smartphones and iPads, et cetera, and they're using them in their clinics and using them to provide care. What do you see as that impact, and how do you see that evolving and influencing the type of transition we're going to go through?
I think it's on twofold. The consumerism trend that you talk to is in our consumer lives as clinicians. We start to use tools and devices that are actually more advanced than the ones we use at work. It used to be in many ways beforehand that you got your computer at work, it was delivered to you, this was really cool, and then you kind of figured out maybe how you got that into your home life. Now the tools that you can buy at Best Buy are actually more powerful and more innovative than you get in your workplace. So you go, ow, I want to bring those tools forward. So that's in one sense that it's taking an industry that was often reluctant to adopt new processes and methods and making it happen much quicker and faster than it otherwise might. But the second thing is, you know, the concept, there's an app for that. So if I actually want to look at changing behavior, because you began to comment about wellness. So how do I actually use these tools in consumers' hands to change behavior? If I'm a clinician and you visit me every 3 months for diabetes, that's not going to change your behavior. That's not going to help you act better and understand nutrition. But if I had an app in your pocket that might help you make better decisions at mealtime, that was context aware, that was based on your activity level this morning because it's attached to your pedometer, it attaches to your calendar, it knows that you know, you're going to go do something that's really active today versus, you know, I'm going to sit here all day long, versus I'm going to go work out at the gym, and it knows that when I ate breakfast and what, on and on. The more context I add, the more valuable that information becomes to the consumer. And there's no way a clinician could mimic that. So it's like having a clinician in your pocket in a context-aware manner to empower the citizen to make more elegant decisions. You know, diabetes is one, asthma might be another, CHF might be, on and on for helping manage chronic disease and prevent those acute exacerbations, which lead to the hospitalizations and what drives cost. So increasingly the sensors get better. The sensors get more intuitive. They get more prolific. The sensors are in your car. Not just airbag sensors, but sensors monitoring your heart rate, your heartbeat, not just when you have an accident, but when you're out and about. It's one thing if the sensors work at home, but you know, we're out and about right now. How do the sensors help me in this environment? And I think you start to see that integration of information, which mitigates the need to always contact the healthcare profession, which then takes demand down, which helps lower cost in a time of rising need because of an aging population.
I think that consumerism has an additional dimension that has real power that is still one of the really thorny issues in biomedicine and in health in specific, and that's who owns the data. So one of the challenges we have right now, appropriately so, is the protection of data, who's allowed to access data, under what circumstances can you use it, how can I share it with other individuals. Well, putting the consumer at the center of this actually amazingly clarifies the regulatory framework. Much the same as I as a consumer can choose in every other dimension of my life who I choose to share my data with, by giving that individual that control, you no longer have the issues, again in the United States, exploding is the regulatory framework around HIPAA and who can actually touch what data under what circumstances and who has what business associate agreements, so that I could actually share this with this clinic or that clinic, or can this researcher touch this data? Well, the consumer actually at the center of all of this suddenly has the ability to say, I want my data used in these contexts. And what we find, at least in my field, in cancer research, we find that consumers actually quite commonly want their data to be liberally available. Not necessarily, when I say their data, they don't want their address and their phone number, but they want the sort of health characteristics that's part of their day-to-day life. They don't mind that being part of a much broader ecosystem. And by liberating that ecosystem, then there's a e-patient Dave is famous in a variety of contexts, and his mantra is, give me my damn data. So by giving people their data, you can actually facilitate all these apps, and you can actually create these large reservoirs of experience and observation. A personal example of one of the things I know I was immensely hungry for, actually, I had a shoulder injury a couple of years ago, and wanted to figure out what was the best type of intervention I should have. Well, interestingly, because there's no drugs and almost no even surgical difference in this, there's no literature about this sort of stuff. Now, it doesn't mean that people aren't having treatments and surgeries all the time, but there's just no place to go to get a reservoir of information. There's not a deep medical literature. What if everybody, like in a patients like me context, had the ability to share out just venues where they could actually share out, not necessarily identified, but what were their experiences? You get an incredible transformation. Richard?
So I just happened to look up the word, the meaning of consumerism in Wikipedia the other day, and it says the purchase of goods and services in even greater amounts. Well, quite frankly, nobody in their correct mind wants to purchase more goods and services from the healthcare system if they can help it. But it also means consumer protection and activism. And I think what we're going to see is the innovation in the technology which derive consumerism, which derive then the democratization of medicine. And Eric Topol has written this great book on the creative destruction of medicine, driving to the democratization of medicine. It's rather interesting that in the past, we've seen technology that's been used in the business place. Then after a while start being used by the consumer. Email is a good example of that. Discussion forums is another good example of that. We're starting to see the reverse now. We're starting to see products and tools that come from the consumer. Facebook, a good example for family and friends, now starting being used in the business. And I think consumers in every field of their life can now start to interact with their banks, with their providers of services, and they will demand over time that same level of interaction with their providers of care. I couldn't agree more with Ken that, it's my data, damn it, right? So I want access to that data. And by the way, I then get to share it with whoever I like. I think with the whole issue around crowdsourcing and the sharing of data for patients like me, from an individualistic point of view, we're going to see more and more of that over time. I just worry about one thing, and whilst I agree with Mark in terms of the aspects of monitoring, I think some of you may have seen this ad. It was a spoof where this guy who's a heart attack patient was monitored for blood rates and blood and heartbeats and blood flows and heart rates, etc. And of course, this monitoring takes place at the same company that is home security, that actually does home security for him. And he's sitting there having dinner, obviously while being monitored, and the door breaks down, and the paramedics are there. They tell him, "You're just about to have a heart attack." So I just wonder whether we're going to become, a global world of hypochondriacs with the amount of monitoring that's going to go on.
Interestingly, there hasn't been much research on this, but there was some stuff done in Europe about 15 years ago where they actually went to the patients and talked to them about their information and sharing. And what comes out, and we've done a bit of work through the Canadian Medical Association Canada with the public, to the point that was made. All the individual wants to know is that you would like to use their information. Very few people will actually withhold information if they know it's going to be for research, it's going to be used for public health, it's going to be used for public health surveillance. People are very open. Unless you're very libertarian and you don't want anybody, you want to withdraw from society, you don't want anybody to see anything about you, we find it's very open. So my observation is, and at least I'll talk in the Canadian context, and I'd like Ken and Mark to talk about the U.S. context, our governments have not done a very good job in going to the public to say, this is what we'd like to use your information for, and oh, by the way, we'll tell you every year how we've used your information. And we're going to use it to do some cancer studies, and we're going to do it because we're seeing an increase in colon cancer with certain types of demographics of groups out there. People don't mind that. So, but it always intrigues me why a government would not go out and actually let people know the value, because I think the public would come back and say, I'm okay with that. So I'd like the comment from our panels, but could I ask Ken or Mark, given down the U.S. with HIPAA and what's going on, I mean, is that something that would work?
You go back, I think, to the paternalism. Who owns the data? Who has the power? I think most clinicians would tell you it's their data, it's their work product. I think what they sometimes forget is it wasn't altruistic. They got hired for a period of 15 minutes to produce that work product. Things like lab data. If you order a lab test, who does the lab test go back to? It often goes back to the clinician. Why doesn't it go back to you? I actually have a weird privilege being the worldwide medical director. If you were in Singapore, the data would come to you at the same real time. If you were in Israel, you might even get the data before the doctor got it because it would come to you on a WAP on your cell phone. Because they realize it's your data and you're empowered for it. There are 18 states in the United States that actually forbid you from giving the data directly to the patient. And then just to show you the contradictory regulations, Meaningful Use Part 2 has a requirement that you actually hand the data to the patient. Wouldn't it be kind of nice if it was automated from the source instead of it having to go through the middleman? There's actually data to support the fact that something like 1 in 7 lab values are never reviewed and never reported, and like 1 in 13 x-rays, image studies, are never... Whoa, that's a huge source of malpractice. If the data came to you as a citizen, you become the quality checkpoint. But the pushback from the doctors are, well, what if they get the data and it scares them or they don't understand it? Well, apparently that's not a big problem in Singapore. They actually must have much smarter, more intelligent patients than we do. So I think there's a lot of FUD around it, and I want to control the data. It's my data, and you have to come to me to get it. And as the opening comments, don't go to anybody else. But if it becomes your data, and it becomes now the process where you can transport it anywhere, I go back to the non-local phenomena. It's my x-ray. You know what? I went and got an x-ray, and I wanted to pay for it. I don't want to be gated by... I want a mammography, and I don't believe that the guidelines tell me I should wait till 50. So I got it, and you know what? I want the best doctors at Sloan Kettering to read it. I don't want the guy who did it to read it. So since it's my data, let me send the bits to Sloan. Not different.
Yeah, I'll echo the very complex regulatory framework that is the United States in terms of these types of issues. I was going to make the point that, in fact, as you just said, in many places, there's statewide regulatory resources that actually forbid patients from directly getting their information, which is interesting. I will, suggest that again, at the risk of being provocative, that there's a fair amount of paternalism among many of my colleagues that routinely said, oh, it is immensely dangerous to put this type of data in the hands of consumers and or patients. They wouldn't know what to do with it. They'll be confused. They'll get panicked. They'll do all sorts of things. I guess my perspective on that, though, is if people want it, they, at some point, they'll either get it indirectly filtered through the physician, or they'll get it directly. So, if, they're clearly, there's been, participated with a whole variety of behavioral groups. There arguably are two constructs of people in general. There's blunters and monitors. There's people that actually want information, and there's people, the sort of people that, don't want to know any information. So if you don't want to know your information, there's no obligation. You'd have to take this information. On the other hand, if you're a monitor and you could make productive use of it, it seems that it should be valuable. Now, at the risk of being too colorful again, I'm currently in the state of Arizona, one of the more libertarian or libertarian states. That there's an argument that the people went to Arizona for very specific reasons. They didn't want to be in other contexts where other folks told them what to do or told them what not to do. That said, it's sort of interesting that there's not any correlation in the United States, though, between the sort of libertarian states and your right to access any of these things. And in fact, some of the places that you might think of as being more progressive have some of the most restrictive regulations as to who can access what when, because of paternalism and because of presumptions that state bodies maybe know better than individuals. So it's really a complicated landscape. Richard?
Yeah, so just to go back to Mark's point, we have actually run surveys with Canadians, and they want four things. In every other aspect of their life, they can schedule their appointments, they can book their trips online, they can book their travel, hotels, whatever. So they like to be able to e-schedule with their clinicians. They want to get into e-consultations. They would really like to renew their prescriptions online, instead of having to go back for a physical visit. And the last thing is they want access to their information, but in particular, access to their lab results. And we're already doing that. We're doing that in British Columbia, and as far as I know, no one's left the province just because of that. So that's good news. Now, we've got some pilots going in other places, and it really does depend on the governance structure, and nothing to do with the legislation. So we've got some clinicians, some physicians are saying, well, I think we can give them the results 2 days after I receive it. So we will see how that starts to play out. But, if I go for a lab results, I'm really anxious to know whether it's negative or positive. And today you can do a cholesterol test. You can actually do it in a meaningful way so that somebody doesn't have to go through 8 years of med school to read the results. And Bill, just on one comment to your comment around the consumer and allowing people to use this data. We've done studies around that. We're always doing studies, especially around secondary use of data. And Canadians, when you talk to them about the data being used for research purposes, etc., are quite happy to collaborate as long as it's done on an anonymized basis. If it's not on an anonymized basis, they would really like to have to give their consent. What's getting troubling, I suppose, and we stay well away from it, but I noticed in the States, there's lots of conferences on the monetization of big data. And that scares the pants of a lot of people and consumers to say, who's going to get access to my individual data, and what does it mean to me, and what can they do from a marketing perspective?
Well, that actually leads into the whole idea of opt-in or opt-out. Do you opt in for the data transfer or opt out? And in the U.S., it's a patchwork of regulations, almost state by state. But let me share 3 countries' experiences as opposed to the U.S. England actually has a system that they put in place that we were discussing where data can now be transferred. Summary care records can be sent to any clinician, any institution in the country, and they had an opt-out policy. And at last I heard less than something like 1/10 of 1% of the population opted out. Holland decided to go the other way and have an opt-in policy and build a personal medical record. They spent literally several $100 million advertising the benefit of the record and transferring it. And after a concerted mailing program, they got 28% of the population to opt in. Opt-in may not work. And then you have France, which is requiring dossier medical personnel a personal PHR for citizens because it lowers the cost of care, and at some point will introduce a fine if you don't make the data available to the clinician who's then treating you, and it's the citizen's responsibility to have the PHR and present it. We can't even agree in the United States to make people get insurance, let alone own a PHR.
Would you like to get on this again?
Oh, sure. Why not? Well, because I think that raised one of the elephants in the room, at least in the United States, that's tying up the issue about data, and it has to do with monetization. There is tons of interest and/or conflict of interest is to, with people sometimes wearing white coats and large-scale prestigious institutions arguing they couldn't possibly, for moralistic reasons, share data. At the same time, they're selling it to very large groups and making tons of money doing that same process. So, I do think one of the things that we need to make more transparent is what are the circumstances, who benefits, who doesn't benefit from this. And again, I think as Bill pointed out, there's almost always uniform, acceptance that people want to share their data for medical research and a variety of other things. But introduce, instead of saying medical research, say, do you want pharmaceutical companies to have access to your data? Which actually do medical research. You get a absolutely polarly different answer, partially because the monetization. People want to know who's benefiting from this. And if I'm contributing to this, they don't understand why in this sort of non-transparent universe they don't get benefit from it.
So let me shift gears a bit here. One of the complaints, certainly in the Canadian context, we continually get from ministers and people who observe on the whole digitization process we're going, why is it taking so long? We've been 10 years into this and we still have not seen, my record is not captured with my physician and I can't do these types of things. And you've got a different approach in the U.S. where you've got through your Medicaid, Medicare, you've got actually a very interesting incentive to move that along. Through Dick's organization, he's been doing a lot of great stuff across the country, trying to work in our federated environment, which creates a challenge as to how we move it. So what I'd like to do, your question to the three of you is, if there were some things that you could see happen that would accelerate the digitization process, what would they be? So Dick, can I start with you on that?
Yeah, so, why is it taking so long? I get asked that question really the whole time. And, maybe, although one of the paths of why it's taking so long is when you see, millions and millions and millions of files of paper, which you now got to digitize and you've got to convert. So that in itself is a big issue. But the biggest issue is culture. It's not the hardware, it's not the software, it's the culture. It's the culture of change management. We have the majority of our physicians and nurses who have left med school and nursing school, of our pharmacists 20, 30 years ago, and now teaching them to use new tools and adopting it is the huge challenge. And so certainly from the clinician's perspective, they need to be convinced of the value add proposition. We're going through a process where in some cases clinicians who are 10 years out from retirement are saying, this is not for me, the EMR is not for me, because I'm retiring in 10 years. And we actually ran a bit of a challenge a few months ago where we got three clinics that were still on paper and 3 clinics that were on the EMR. And we said to them, we want you to do 3 things for us. We want you to find all the patients who have had a heart attack within the last month, your patients. We want you to find patients that are going through some of the cancer treatments right now. And here are 2 drugs that need to be recalled because they're unsafe. Can you find them for us? And the people who are on them. Well, the guys with paper they gave up after 40 hours. The guys with the MRs, after just over an hour, with a high confidence level, they said, here are our patients. Well, if that's not a value add from a quality, a treatment perspective, I don't know what is. But, that said, it's still extraordinarily difficult. And so the issue has been, the change in culture, the cost, who gets to pay for this? The incentive, disincentive, the Obamacare Act in terms of what they're doing, I think they could have got it right. I'd be interested to hear from my other two colleagues in terms of the incentives. If you do this, you'll get more. And if you don't do it within a period of time, you're going to get less than you're getting now. So what we've seen in Europe is a variety of incentives that have gone in, or in Australia and New Zealand. But then at some stage, they say, governments typically say, or the payer says, this is the standard of care, and we will legislate. Or if you want to work in this facility, you're going to have to use this. So it's a matter of a stick and a carrot. It's a matter of a value proposition, but it comes down to change management of accelerating the process.
Yeah, I agree completely. And I think in the context of incentives, it's in many ways an overburdened word. Part of the things my group works on all the time is vocabulary and the complexity of vocabulary. But, so clearly, for instance, the U.S. Current strategy is to financially incentivize folks, at least in the initial rounds, by giving a bonus, and then ultimately by starting with carrot, then moving to stick. That gets people to a point. But I think one of the things we need to always recognize in the adoption of any new technology has to do with, what are the benefits that come from that technology? And I think one of the challenges that we still face with the digitization of healthcare is, who do the benefits accrue to? And for too many of the systems that physicians have to sit down in front of, or other care providers have to sit down in front of, it's actually not in any way directly benefiting them. It's they're tasked with putting in a bunch of data, or changing a business practice that may or may not change anything that they're doing in any real form, but the benefits don't so much accrue to them. They accrue to payers, or they accrue to other groups by having more liberation of data. So I think we've got to be very focused in incentives that it has to have direct benefit to the people who are using the system. And what we also see is that we too commonly don't engage them well enough. So for instance, there's discussions that we have clinical decision support systems, but not uncommonly when we implement them, you go into alert mania, or it's not clear that there's actual real benefit occurring. So I think incentives are critical, but they are oftentimes as important they're not intangible. They're actually related to the actual delivery of health care. The incentives need to be that I can do a better job treating and providing care for my patients. Back to this setting context, back to better clinical decision support, better things that actually improve my life.
I'm going to be a bit more jaded and take a slightly different tact. When people say, who does the benefit accrue to in the externality, they often talk about payer. But I'm going to say the benefit accrues to the citizen. That's the beneficiary of EMR based on what you just said before and the 3 data points you just offered. We take care of the citizen, the patient, better, more efficaciously, and maybe, again, from the jaded aspect, we kill them less efficiently. If you actually look at, I think the fundamental reason it's going so slow is there's no consumer demand. The patients don't expect, you sit there and write on a paper record, hand them a written prescription, they're okay with that. Whereas in most other parts of your life, if you actually didn't get digital data, or somebody couldn't email you something, or you couldn't do it online, you'd go somewhere else. Would you do that with your doctor? Would you change a doctor? Would you change a hospital? Would you do something different? That will start to drive demand if the citizens actually came in and expected it. Now, if you actually look at the statistics and why a citizen should expect it, we're pretty good at guarding them. So 10 years ago, 11 years ago, the first landmark study, Air is Human, came out. We estimated 44,000 process deaths in hospitals. Now, I dare to think if that was going on in the hospital with everybody watching me, what the heck's going on in my office when I'm doing it by myself? But then Healthgrades comes out and says it was underestimated. If I go with 100,000 deaths a year, that makes the U.S. healthcare system the 5th leading cause of death in the United States. That's an interesting way of looking at the healthcare system. So you better be damn sick before you go to the hospital and have the chance of the hospital killing you not be exceeded by the chance of your illness killing you. Most citizens wouldn't think that way. Most citizens wouldn't understand when you get a written prescription, 17,000 people a year die through prescription errors. What if we criminalize that behavior? Not malpractice, it's criminal. Because it's negligence at this point because you don't have the tools. The Danish Medical Society in 2004 decided by the end of 2006, if you want to belong to the medical society, wasn't the government, wasn't the regulations, it was the doctors. They said, if you want to belong to the Danish Medical Society, you e-prescribe or you can't get a license from us in Denmark. It's only 5,000 doctors. It's a small little country, but looking at what it does for the citizens, if we actually had national programs that actually went to the citizen and said, here is the benefit, and then dare to actually put down the negative, the AMA would shut, the CMA, they would shut them down so fast. When the Medicare Modernization Act of 2003 came up, it was going to mandate e-prescribing over a certain period of time, about a decade. Both the AMA and the American College of Physicians in the United States worked vigorously to defeat it, called it an unfunded mandate with no evidence, while the Danish Medical Society mandated it for their doctors. I'll leave it at that.
Thank you. I want to move on to another area, and Ken, I'd like you to take this on initially, and it's all about medical research. And as we start to digitize the care system, we are now actually creating some ways of collaboration in the research world and developing more knowledge in ways that we never could have done before. Could you, because that's an area that you've been in a long time and you've gone through some of the, I assume, just the paper processes, and now maybe I'm assuming you're actually getting into situations where you now are getting all your information digitized.
Yeah, this is epiphanal to the medical research community, and the capacity to be able to have digital information really is empowering us to take a fundamentally different look at how we do biomedical research. Now, it's like everything else, it's a transition, and we're not doing it all at once. 30-second digression, most of what we do today in biomedical research, for the most part, is really small-scale, individual laboratory-based activities, because the cost of doing anything larger than that was actually prohibitive. Well, in a digital age, we actually have the capacity to really start to transform biomedical research from its sort of mom-and-pop shop view of the world into what's transforming everything else in the world economy: big data-based approaches, new approaches to analytics, new approaches to integrative exploration. But I think the other thing that the digital revolution is facilitating is actually also one that's, again, is equally troubling to researchers as what we're hearing about the liberation of data in a care setting, and that's moving to consumer-based research initiatives, where, in fact, not only do we actually look at consumers owning their medical record, but consumers own their medical research data, or help drive, or help solicit, or contribute, or organize the medical research in digital communities, where we start to have key stakeholders, advocacy groups, other groups now actually start to facilitate the organization and consumer-driven class of questions that are starting to be asked. So by liberating the data, we have the capacity to do things that we couldn't do in the past. There's a second dimension, though, if you'll give me 15 more seconds, and that's that we also have the ability to move away from the reductionist paradigm that has been invaluable for the last 30, 40 years, where we essentially, to solve or address any issue in biomedicine, we have to reduce its complexity down to, we control out. Anytime we do a clinical trial, we remove all the concomitant conditions. We remove and focus like a laser on a single variable. I'll point out that I don't need to tell any of the physicians in the room, or that very few people present at a doctor's office in the pristine state that actually is what is tested in a clinical trial. We have no idea, for the most part, actually how to translate that pristine state back into the complex state that is multivariate, multi-disease, multi-symptoms. So what we have the ability to do with the digital revolution is to embrace the complexity of healthcare, to embrace and recognize that disease is a complex adaptive system. It's not a simple single variable type of event. And it actually requires us to really understand that broader context again.
Just to emphasize the same points that you're making, it becomes an interesting big data issue now. And as we can actually aggregate big data and actually look at the same types of solutions we're applying to hospitals and to cities and big data grids, if I can actually look at a cancer problem and look at how an open source Hadoop could actually start to bring together disparate resources in disparate hospitals in 11 or 8 different centers and actually aggregate them up to a meaningful number so they can get a meaningful result, you can get the things a whole lot quicker and a whole lot faster with digitization. With in vivo imaging studies and the ability for imaging platforms to get down to the molecular level, if you will, in real time, you can actually start to get dramatically changes in how you actually get outcomes instead of actually waiting for population-based outcomes. And finally, just simply even an inclusion and exclusion criteria to populate a trial. It used to be one of the biggest expenses in actually getting research off the ground. Now with patients like me and people who want to expose their information and voluntarily put themselves out there, you can actually now change recruitment and exclusion. And you could actually realize the reason I'm not getting one is my exclusionary criteria, produce the null set. So, and that took a lot of money to find that out. Now I could find that out much quicker.
Richard?
Well, I don't have the same passion that both Ken and Mark just exhibited on this, the epiphany in terms of big data and everything else. And I never thought about the fact, of course you should, with the whole area now of crowdsourcing, certainly medical researchers can add a lot of other folks who can come up with some of the answers. The question for us, of course, is, 80% of the medical data that we have is still non-standard data. And so we're going to have to rely on certainly the natural languages getting a lot better so they can parse and understand the spoken and written word. And I think that's going to be absolutely crucial. That's why I'm fascinated by some of these engines that they're now building that say they can get, terabytes of information in 3 seconds and give you some confidence in terms of what the diagnostics are, given that a lot of the data that they're hitting in the internet, by the way, is unstructured data as well. So my question, I'm probably taking over your job, is
that's no change, Dick, in all the years we've known each other.
The question is, so now we have the whole era of genomics coming on, and personalized medicine. So how is that going to change clinical trials, which are typically based on populations before?
Oh, it's going to radically change how we do the whole biomedical research endeavor, because basically we'll now have the ability to bring in to the context all of those underlying differences, both in the molecular basis of the individual as well as the molecular basis of the disease. So, and in fact, those aren't always the same either. So especially when one looks at, again, the field I work in, you have huge differences. For instance, if you just scan my DNA, the DNA copy set I got from my mom versus the DNA copy set I got from my dad has a million differences in it. So that are actually not just sort of random differences, they're spread out throughout the genome, and as we've seen from
Which ones are better?
That actually help us or hopefully don't help us understand what happens to disease. When we go into a disease like cancer, we see that, in fact, speaking of a complex adaptive system, cancer itself is an evolutionary process by which you actually have a new organism growing in yourself that's changing and evolving on a day-to-day basis. So what we're going to have the capacity to do is have, first off, a snapshot of how those differences are be available on a day-to-day basis in terms of directing clinical research and being able to see how those differences, those molecular differences play out. Now, we get to the rub. The average person has a real difficult time processing a million differences. I'm not saying there aren't people in the room here or people on the panel here that can't actually click through that, but most people hit a cognitive ceiling at around 100 to 1,000 different variables in their head. Now suddenly, so we're going to have to come up with smarter ways to actually embrace this information. There's an argument that we're going to need almost this next generation liberation of clinical data to be able to sort through which of those million differences really are meaningful or drive response or affect outcome. Because if you actually have that high of multidimensionality, you've got to have much more control and much more capacity to be able to leverage unique collections of individuals with unique collections of clinical information. So that, ironically, the system could collapse with the introduction of this variability rather than be liberated by it.
If you actually look at the amount of data we're talking about for one genome, like 500 terabytes, but how recent does it have to be since your genome evolves and mutates? If this was a genetic profile for you 5 years ago, is it relevant anymore? Should I retype you? How many 500 terabytes of data on you do I have to store? And then where do I put it? So one of the concepts in a compute model is if the data for you is going to reside in a personal location, I want to move the application to analyze it to the data versus move the data to any central repository.
So, and you've touched on something interesting because one of the last jobs I had in the federal government was to put together a plan with the provinces, territories on the type of digitization agenda we want to follow in Canada, and Dick picked it up and has evolved it and has really moved along. But the technology at that time and what we thought we could do is almost antiquated given the capacity with things we can do now and the capabilities. And we've heard many examples over the last day and a half. So the interesting question is, before we were building databases to hold data in central repositories, now we've got a capability to, and I like the way that they've rephrased it in the United States. It isn't bringing, pulling data together and pulling them up to the questions. Is you're pushing the questions out to the data sources, and based on your question, they're actually now giving you anonymized data sets that match the profile of the issue or the people or the demographics that you want to do. So is that where we have to go? Is it doable? I mean, Dick, is this the type of evolution we have to take a look in Canada? Like, where do we go with this now?
Well, to me, the rate-limiting step on this, at the risk of now raining on the sort of digital explosion parade, is the coherence of the data. So for those strategies to work in this distributed, federated universe, we have to have some concurrence on how data is going to be represented so that it can be captured as information. So if we are in a non-standardized world and every little local repository uses a non-compatible dialect for its representation of data, the notion of doing the sort of federated recovery approaches starts to break down. It doesn't mean that it's unusable, but the notion of returning a coherent data set without some commitment to data representation then starts to become problematic. So it does, there's a price to be paid by the non-sort of centralization and or processing of stuff, because you have to have some ability to know that apples are apples and oranges are oranges, or we lose all the grain size. And while it may be interesting to know that everything was a fruit, the notion of separating apples from oranges from bananas may turn out to be really critical in healthcare decision making. So we may not be able to lump everything as fruit.
Okay. Dick, you want to comment on?
Well, yeah, I'm more interested in, everything that Mark said Ken says is absolutely true, but surely there's got to be this tantalizing aspect that now when you go to a medical conference or a medical research conference, you're not just sharing your works based on some of the population in Arizona or all the population in Arizona and other places, but it could be the combination of global data coming together. And surely if you can agree on aspects of synoptic reporting as opposed to a lot of the unstructured stuff, even from a global perspective of being able to work now on very large databases of different folks around the world. And the other thing, since I have the floor, as I was sitting and thinking about your first question on 2025 and on our vision, quite frankly, I think I'm more optimistic for the emerging economies and the developing countries than I am for some of us who are stuck with our staid legacy systems. And how do we join all of those things together? So you know, we're now seeing in India tremendous use of cell phones for prenatal care and stuff like that. We certainly don't see it in North America. So you're going to see the mother of invention happen in some of these countries that we, in certainly some aspects of the Western countries, will be actually learning from.
Okay. And we actually, us developed countries, we may not have to worry, because when we all economically collapse, we'll be back to developing countries, so we can actually take on. We are. So on that, I'm going to close down the panel. I want to thank my three panelists, Ken, Mark, and Richard. Thank you very much for your comments, and once again, thank you.
Thank you so much. That was an amazing conversation. I just learned a ton. And before I let you go, I would like to make my little modest proposal to all the countries of the world regarding collaborative healthcare. Every baby, when they're born, should get a website. And it's half electronic healthcare record and half social network for health. And as the panel discussed, you have full transparency into your own record. Clinicians provide the data, of course, within appropriate security and privacy considerations. But this is your environment, and you have a condition, you go there. It's like patients like me on steroids, perhaps, that you've got diabetes. You go into your diabetes group, and you have a news feed that's giving you all the latest stuff, and you post something, and you research, you investigate, you've got some new symptom, you share. This provides a foundation for science and for medicine, because, again, with appropriate privacy considerations, clinicians and researchers could learn so much, and it could shift the burden of healthcare away from the system. Because we know if you curate the right environment, you can improve healthcare outcomes. This would help us move towards a more evidence-based system, and it would move away from the old industrial model of clinicians delivering healthcare to passive recipients. Take something like diabetes. Well, no, take something like obesity. This is a huge problem in the United States. And everybody knows about this. How are we going to fix this? By lecturing people that they should not eat so much? The number one risk factor in health is isolation overall. If we can enable people to come together and collaborate, maybe we can move towards a new paradigm that can make a real difference. So that's my little rant on healthcare. I hope you'll all go back to your countries and implement that. Thank you very much. Let's have a great round of applause for the